Hello my friends, this is Dr. Syed Kazmi. You're watching my YouTube channel. Now today I'm going to be talking about neonatal hypocalcemia. It's going to be a brief lecture. So I will, in this brief lecture, I would explain what neonatal hypocalcemia is, what are its types, what are its causes, and what is its treatment. Okay, so let's start with the definition. So the definition of neonatal hypocalcemia is when the total serum calcium in a neonate is less than 7 milligrams per deciliter. But keep it in mind that the normal calcium level in the neonates is in the range of 8 to 10 milligram per deciliter, and if you are in the UK, you will be familiar with the millimole system, and in the millimole system, if we convert this 8 to 10 milligram per deciliter, this comes out to be somewhere between 2 to 2.2 millimoles per liter. So in other words, if the total serum calcium is less than 7 milligrams or is less than, you would say, 1.8 millimole per liter, then that would be defined as neonatal hypocalcemia. Please also keep it in mind that the calcium in the body is of two types: total calcium, serum calcium, and the ionized calcium. And the ionized calcium is very important because if the ionized calcium goes down, this is what would manifest as the clinical signs and symptoms of neonatal hypocalcemia. And the ionized calcium level in neonatal hypocalcemia would be less than 4 milligram per deciliter. In other words, it would be less than 1 millimole per liter. So if a total calcium level is less than 1.8 or the ionized calcium level is less than 1 millimoles per liter, then that is classified as neonatal hypocalcemia. Now, neonatal hypocalcemia is of two types. One is the early type of neonatal hypocalcemia, and the other one is the late. Now, the early one is that type of neonatal hypocalcemia that appears in the first 3 days of life. And neonatal hypocalcemia, which appears after that, that would be somewhere between 4 to 7 days of life. That is known as late hypocalcemia. So let's talk about the causes of the early neonatal hypocalcemia. Now, there are four reasons of early neonatal hypocalcemia. The first one is prematurity and small for gestational age, and this includes the low birth weight babies and the very low birth weight babies. And the reason in these babies for neonatal hypocalcemia is because of a lower reserve of calcium. And what happens is that there is low level of the transfer of the calcium from the mothers through the placenta into the baby. So they've got small, like low calcium reserves, and these low calcium reserves can manifest in neonatal hypocalcemia. The other reason is that they have either a low level or immature function of the parathormone, and if this hormone is in low level or if it is not functioning properly, then they would be having low calcium level in their blood. The other reason could be congenital hypoparathyroidism, and this you should suspect if the neonate has got dysmorphic features, or if the chest x-ray shows you a narrow mediastinum, which means absence of thymus. And these babies have got a lot of predisposition to different types of infections, and they would be having definitely dysmorphic features, and it is known as Dye-George syndrome. So in Dye-George syndrome, the problem is in the development of the third and the fourth branchial arc, and there would be aplasia or absence of thymus, and consequently the problems in the immunity as well, and also the absence of the parathyroid glands, which leads to early and can also manifest as early as well as late onset hypocalcemia. Then the third reason is infants of diabetic mother. So if the mother has got a history of diabetes, then these babies are more predisposed to have early onset neonatal hypocalcemia, and it is because of the low parathormone function and high levels of calcitonin, and that can also be coupled with low magnesium levels coming from the mom who is diabetic. And fourth reason is birth asphyxia. Birth asphyxia, asphyxia means the child is asphyxiated, he is not getting enough oxygen, his cells are not getting enough oxygen, so many of these cells, they die, and when these cells they die, they release a lot of phosphate, and these phosphate from the damaged cells coupled with a high calcitonin level can cause a low level of calcium, which can cause neonatal hypocalcemia. Then coming to the late onset neonatal hypocalcemia, which occurs somewhere between 4 to 7 days of age. Again, one reason is high phosphate containing milk, though this is not that much very common in UK, but like in some of the developing countries, this can be seen where the neonates are given whole cow milk, or they are given some sort of inappropriate formula which has got a very high phosphate content. So high phosphate would lead to low calcium, and that can manifest in the form of late onset neonatal hypocalcemia. If they are the second reason is premature babies who are on breast milk. So if the breast milk is not supplemented with vitamin D and oral calcium, and these prematures have got low reserves, so they need more vitamin D and oral calcium. And usually the breast milk, though it does contain some vitamin D and all, it's not sufficient to take care of the needs of a premature baby. So they have got more predisposition to present with late onset neonatal hypocalcemia. The third reason is hypoparathyroidism. Again, it could be congenital hypoparathyroidism, it could be transient because of different reason. I don't want to go into details of that because that would become another lecture for that. Like, need to give another lecture on hypoparathyroidism. But nevertheless, if it is presence, if it is absent right from the beginning in the form of congenital, or there is some problem in the parathyroid glands leading to transient hypoparathyroidism, then it can manifest as late onset neonatal hypocalcemia. Excuse me. It can also occur because of the low maternal vitamin D stores. If the mom is malnourished, if the mom diet is not good and she's breastfeeding her baby, so obviously her low vitamin D levels would manifest in the form of low vitamin D levels in the baby as well, and that can lead to low calcium levels, and that can sometimes manifest as late neonatal hypocalcemia. And last but not the least, renal dysfunction. So if the child has got some congenital renal problem, or congenital hydronephrosis, or dysplastic kidneys or something, they can have problems with the metabolism of calcium and phosphate, and that can lead to low levels of calcium in the blood, and that can manifest in neonatal hypocalcemia, the late onset variety. Moving on to the features. Okay, fine. So whether it's the early onset or whether it's the late onset, what are the clinical features? So please keep it in mind that if the total calcium is less than 7 milligram per deciliter, or the ionized calcium goes less than 4, or some books say 3.5, or in other words, you can say, if we take it in millimoles, if it is less than 1.8 millimoles the total, or if the ionized is less than 1 millimole, then they can present with hypotonia. So in hypotonia, they will have a low muscular tone. They can present with tachypnea because obviously if there is a muscular weakness, so the intercostal muscles cannot function properly, so the child would be definitely getting some form of hypoxia. To compensate that, they would increase their respiratory rate, so these kids can present with tachypnea. Sometimes they can also present with apnea, obviously because if the oxygen levels are going down, it can lead to effects on the respiratory centers in the brainstem and can lead to episodes of apnea. It can also lead to poor feeding because of the poor contraction of the orofacial musculature, can manifest in the form of poor feeding. They might exhibit jitteriness, or they can present with frank tetanic convulsions. But keep in mind that same types of symptoms can also occur in hypoglycemia, because the hypoglycemia can also present with jitteriness, they can also present with seizures, they can also present with hypotonia. But please keep in mind that if we do a blood gas would give you an idea of the glucose as well as the calcium as well. So blood gas is a very good what we call point of care test that can give you an idea if there is something wrong with the blood glucose, or if there's something wrong with the serum calcium. Similarly, if you do an ECG in these babies, so it's going to show you a prolonged QTC, that is the corrected QT interval, and if that is the case, then that's very dangerous because that can lead to arrhythmias. Keep it in mind, premature babies usually needs a very high calcium and phosphate for the rapid growth of their bones, so they need formula which contains high calcium coupled with high phosphate and vitamin D. Or if they are being breastfed, they have to be supplemented with vitamin D after discharge from the hospital. And I'm talking about the premature babies because I told you earlier that premature babies have got low calcium reserves, so they do need vitamin D, they do need calcium. So either you have got special formulas for them, or if not, they have to be supplemented with things. Otherwise, they can develop osteopenia, they can develop rickets of prematurity, or they can present with frank seizures and tetanic convulsions. Treatment. So the treatment, if it is an early symptomatic hypoglycemia, if they are presenting symptoms like jitteriness, like seizures. So you have to give them emergency calcium in the form of 10% calcium gluconate, and the dose is 2 mils of the 10% calcium gluconate per kilogram body weight, and it has to be given very slowly, and you have to put the baby on cardiac monitor to look for any changes in the ECG. And once you have corrected that, then you have to give them oral maintenance, oral calcium on a maintenance dose for some days to ensure that the calcium is in the normal level, and you have also supplement vitamin D in these cases. For symptomatic late hypocalcemia, you should do correction of the formula with the calcium to phosphate ratio of 4:1. So for every 1 part of phosphate, they have to have 4 parts of calcium as well. And you have to prescribe some oral vitamin D drops and oral calcium as maintenance as well. So this was all about neonatal hypocalcemia. I hope you have understood. This was a very brief lecture just to tell you about the definition, the types, the presenting features, and the treatment. Thank you very much and have a good day.